Welcome, future nurses. As we all know, we are practicing daily 2 or 3 NCLEX test videos. Today, we will be focusing on the nursing care of clients with disorders of the thyroid gland, one of the most important regulators of the body's metabolism. Disorders such as hypothyroidism, hyperthyroidism, goiter, and thyroid cancer can affect energy balance, heart function, growth, and overall well-being. As nurses, our role is to recognize the subtle and sometimes life-threatening signs of thyroid dysfunction, provide safe medication administration, and educate clients on long-term management strategies. In this lecture, we will review the pathophysiology, hallmark signs and symptoms, priority interventions, and NCLEX high-yield strategies that will help you approach thyroid disorders with confidence. By the end of this session, you will be well prepared to assess, intervene, and support clients with thyroid conditions in both acute and chronic settings. Hold for a moment, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package, designed to cover every part of your NCLEX prep. Interactive live classes and easy to watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks, and a PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail during comprehensive lecture. This isn't just another review, it's everything you need in one. Please scan the QR code right now or use the link in the description to enroll instantly, and I'll grab free content including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us continue with another important NCLEX-style scenario to strengthen your preparation. A 35-year-old client seeks medical attention to determine the cause of secondary amenorrhea, and the physician orders a radioactive iodine uptake test to evaluate thyroid function. After the procedure, the nurse must provide discharge teaching. The question asks, which statement is the most accurate for the nurse to include? Here are the options. Option 1. You must remain isolated until the radiation level decreases sufficiently. Option 2. You're free to go without further precautionary instructions. Option 3. You must follow special precautions for a short period of time. And Option 4. You'll be given an antidote to reduce the radioactivity level. The correct answer is Option 3. You must follow special precautions for a short period of time. Here is the reasoning behind it. A radioactive iodine uptake test is a diagnostic procedure that uses a very small dose of radioactive iodine, either orally or intravenously, to assess how effectively the thyroid absorbs iodine. This is particularly useful for diagnosing hyperthyroidism, hypothyroidism, or thyroid nodules. Even though the radiation dose is minimal and poses no long-term risk, it is excreted in urine and other body fluids. Because of this, clients must follow short-term safety measures for about 1 to 3 days. These include flushing the toilet twice after use, washing hands carefully, rinsing sinks and bathtubs, avoiding close contact with pregnant women and children, and using separate towels or linens. This teaching ensures the safety of household members while protecting the client. Importantly, there is no need for prolonged isolation because the radiation dose is too small to cause significant hazard. Now, let us consider why the other options are incorrect. First, Option 1, you must remain isolated until the radiation level decreases sufficiently, is not appropriate here. Extended isolation applies to therapeutic doses of radioactive iodine used for thyroid ablation in hyperthyroidism or thyroid cancer, not for diagnostic testing. Recommending isolation in this context could cause unnecessary fear. Next, Option 2, you're free to go without further precautionary instructions, is also inaccurate. While the test is safe, it is misleading to omit all precautions. Even a small amount of excreted radioactive iodine could expose others, particularly children or pregnant women. So precautionary education is a must. Finally, Option 4, you'll be given an antidote to reduce the radioactivity level, is incorrect because there is no antidote for radioactive iodine. The tracer naturally leaves the body through renal and gastrointestinal excretion. Nurses should instead encourage hydration to promote elimination, not suggest treatments that do not exist. Here is your Stancoast Pearl to lock this concept in. Always distinguish between diagnostic and therapeutic radioactive iodine use. Diagnostic uptake tests use low doses, are done on an outpatient basis, and only require short-term precautions. Therapeutic ablation involves higher doses that demand stricter precautions, including possible isolation. For the NCLEX, remember that if the question is about diagnostic testing, the correct answer will emphasize short-term precautions rather than long-term isolation or antidotes. Let us now move into another advanced NCLEX-style question to sharpen your preparation. A 42-year-old female client presents with progressive fatigue, cold intolerance, facial puffiness, and amenorrhea. Diagnostic testing confirms myxedema, which is the severe form of hypothyroidism. The question asks, in addition to amenorrhea, which other clinical manifestations should the nurse expect to observe in this client? Here are the options to consider: hoarse, raspy voice, oily skin with large pores, thin trunk and extremities, extreme restlessness, low body temperature, and decreased blood pressure. The correct answers are option 1, hoarse, raspy voice, option 5, low body temperature, and option 6, decreased blood pressure. Starting with option 1, hoarse, raspy voice, this is correct because in hypothyroidism and myxedema, mucopolysaccharides accumulate in the interstitial tissues, leading to thickening of the vocal cords and edema in the oropharyngeal region. This results in a classic hoarse, raspy voice and sometimes slow, slurred speech. It is an important indicator of the characteristic tissue infiltration that defines myxedema. Moving on to option 2, oily skin with large pores, this is incorrect, since oily skin is typically seen in hyperthyroidism due to increased metabolic stimulation. In contrast, hypothyroidism leads to dry, coarse skin, brittle nails, and hair loss because of reduced glandular activity. Shifting attention to option 3, thin trunk and extremities, this is also incorrect as this finding is more consistent with Cushing's syndrome caused by muscle wasting and fat redistribution. In hypothyroidism, the client usually gains weight and has puffiness and edema due to slowed metabolism. Now, considering option 4, extreme restlessness, this is not correct because restlessness, anxiety, and irritability are more typical of hyperthyroidism, which stimulates the sympathetic nervous system. Hypothyroidism produces lethargy, apathy, and slowed mental processes instead. Looking at option 5, low body temperature, this is correct and highly significant. Hypothermia occurs because the slowed basal metabolic rate decreases heat production, making clients extremely intolerant to cold. In severe cases such as myxedema coma, hypothermia becomes profound and life-threatening. Finally, option 6, decreased blood pressure, is also correct because hypothyroidism leads to bradycardia, reduced myocardial contractility, and decreased cardiac output, all contributing to hypotension. Severe hypotension in these cases can be an early sign of impending myxedema coma, which requires urgent intervention. To bring everything together, myxedema is the most severe form of hypothyroidism and represents a medical emergency if left untreated. The condition involves a systemic slowing of metabolism, presenting with fatigue, bradycardia, hypotension, hypothermia, facial puffiness, dry skin, and lethargy. Reproductive changes like amenorrhea are also common because the hypothalamic pituitary thyroid axis is disrupted. Nurses must be vigilant in recognizing early warning signs to prevent progression to myxedema coma. Here is a Stancoast Pearl to help you remember. Myxedema equals metabolism at a minimum. Expect hypothermia, hypotension, hypoventilation, and hypoglycemia. All critical signals that the body's systems are shutting down. Recognize these changes early and intervene promptly to save the client's life. Let us now continue our NCLEX preparation with another carefully structured practice scenario. A nurse is completing an admission assessment on a client diagnosed with myxedema, which represents the severe form of hypothyroidism. The question asks, which subjective symptom is the client most likely to report during the health history interview? Here are the options to consider: difficulty urinating, intolerance to cold, profuse perspiration, and excessive appetite. The correct answer is option 2, intolerance to cold. Clients with myxedema commonly complain of feeling extremely cold, even in warm environments. This occurs because thyroid hormone deficiency leads to a dramatically lowered basal metabolic rate, reduced oxygen consumption, and impaired heat generation. Since triiodothyronine, T3, and thyroxine, T4, normally regulate thermogenesis, their absence makes the body unable to maintain warmth. As a result, clients often bundle in blankets or multiple layers of clothing and report cold intolerance as one of the earliest and most consistent symptoms. Turning to option 1, difficulty urinating, this is incorrect. Although severe hypothyroidism may contribute to fluid retention and edema, urinary difficulty is not a primary manifestation. Conditions such as prostatic hypertrophy, urinary tract obstruction, or neurologic dysfunction are more closely linked to this symptom, making it a misleading choice in this context. Looking at option 3, profuse perspiration, this finding belongs to hyperthyroidism rather than hypothyroidism. In states of increased thyroid hormone, metabolism and sympathetic drive are heightened, leading to heat intolerance and excessive sweating. By contrast, myxedema causes dry, coarse skin, brittle nails, and decreased glandular activity, so diaphoresis is not expected. Finally, with option 4, excessive appetite, this is also incorrect. A strong appetite is typical of hyperthyroidism due to elevated metabolic demand. But in hypothyroidism, metabolism slows, leading instead to reduced appetite, weight gain, lethargy, and constipation. Clients with myxedema gain weight not because of overeating, but because of sluggish metabolism and fluid retention. From a clinical perspective, the key concept here is that cold intolerance is the hallmark subjective symptom of hypothyroidism and myxedema. Recognizing this early allows for thyroid testing and timely treatment, preventing progression to myxedema coma, a life-threatening emergency marked by hypothermia, hypotension, hypoglycemia, and hypoventilation. Nurses should document this symptom carefully, provide comfort measures such as warm blankets or room adjustments, and monitor for bradycardia and hypotension as part of safe care. Stancoast Pearl. Always remember, think cold equals low metabolism. When a client says, "I cannot stand the cold anymore," hypothyroidism or myxedema should rise to the top of your nursing differential. Let us now move into another important NCLEX-style question that focuses on discharge teaching for a client diagnosed with myxedema. The question asks, a client diagnosed with myxedema has been prescribed levothyroxine, also known as Synthroid, 1 tablet by mouth daily. During discharge teaching, which client statement demonstrates the best understanding of this prescribed therapy? Here are the options to consider. I must take this drug after meals. I should avoid driving when sleepy. I'll need to take this drug lifelong, and I can skip a dose if I'm nauseated. The correct answer is option 3. I'll need to take this drug lifelong. This is the best evidence of understanding because thyroid hormone replacement therapy is not a short-term treatment, but a lifelong necessity once hypothyroidism, particularly in its severe form such as myxedema, has been diagnosed. The thyroid gland can no longer produce adequate thyroxine, so synthetic replacement with levothyroxine is essential to sustain normal metabolism, maintain cardiac output, support oxygen utilization, and preserve neurologic function. Stopping the medication abruptly or failing to take it consistently can cause recurrence of hypothyroid symptoms and, in extreme cases, progression to myxedema coma, a medical emergency. Therapy usually begins with a low dose to avoid cardiac complications such as angina, arrhythmias, or heart failure, especially in older adults or those with coronary artery disease. Doses are then gradually titrated based on thyroid-stimulating hormone and free thyroxine levels, along with clinical improvement. Continuous monitoring of medication interactions, age-related changes, and organ function is crucial. This makes lifelong adherence the most critical takeaway. Now, let us review why the other options are not correct. Starting with option 1, I must take this drug after meals. This is incorrect, because levothyroxine should always be taken on an empty stomach, preferably in the morning with a full glass of water, at least 30 to 60 minutes before food. Foods rich in calcium, iron, or soy interfere with absorption and can cause subtherapeutic levels if the drug is taken with meals. Looking at option 2, I should avoid driving when sleepy. This may sound safe in general terms, but does not demonstrate understanding of levothyroxine therapy. In fact, levothyroxine is prescribed to reverse fatigue, somnolence, and mental slowing caused by hypothyroidism. Sleep disturbances or restlessness may occur if the dose is too high, but but avoiding driving when sleepy is not directly linked to proper therapy knowledge. Finally, option 4, I can skip a dose if I'm nauseated, is also incorrect. This statement is unsafe because levothyroxine must be taken consistently every day at the prescribed dose. Skipping doses leads to fluctuating hormone levels and destabilization of thyroid balance, which can result in recurrence of symptoms and complications. If nausea occurs, the client should consult their healthcare provider rather than independently changing the regimen. To highlight this with a Stancoast Pearl, always remember that hypothyroidism requires lifelong thyroid hormone replacement. The golden rule is to take levothyroxine on an empty stomach, in the morning, with water, and to monitor thyroid labs regularly for dose adjustments. Watch for drug interactions with calcium, iron, soy, or antacids, and never stop the medication abruptly, as doing so can precipitate a myxedema coma. All right, future nurses, let us dive into another high-yield NCLEX scenario that sharpens your critical thinking around safe medication administration. Imagine this. A client recently diagnosed with hypothyroidism has just been prescribed levothyroxine, also known as Synthroid, for the very first time. In the early days of thyroid hormone replacement therapy, the nurse must be vigilant for warning signs of over-replacement, which can mimic hyperthyroidism. The question is, which signs and symptoms should alert the nurse to possible complications from excessive thyroid hormone levels? The options given are dyspnea, palpitations, excessive bruising, raised red rash, hyperactivity, and insomnia. The correct answers are dyspnea, palpitations, hyperactivity, and insomnia. Let me explain this step by step so it sticks clearly in your mind. Levothyroxine is a synthetic version of thyroxine, the body's natural T4 hormone. It boosts metabolism, cardiac output, oxygen demand, and neurological activity. If the dose is too high, the client essentially shifts from hypothyroidism to iatrogenic hyperthyroidism. That is why monitoring for adverse effects is crucial. First, when we look at dyspnea, this is correct. Excess thyroid hormone raises the basal metabolic rate and oxygen demand, straining the heart and lungs. The client may feel short of breath, especially those with pre-existing cardiac disease. This is an early red flag for possible cardiovascular compromise. Next, palpitations are also correct. With thyroid hormone excess, the heart becomes very sensitive to beta-adrenergic stimulation. Clients may feel a racing or irregular heartbeat, which can progress into atrial fibrillation or even heart failure if unchecked. Recognizing palpitations early helps prevent life-threatening complications. On the other hand, excessive bruising is incorrect. Bruising is not linked to levothyroxine. Instead, it points to possible bleeding disorders, platelet problems, or anticoagulant use. This distinction helps the nurse avoid wrongly attributing unrelated issues to thyroid therapy. Moving forward, a raised red rash is also incorrect. True allergic reactions to levothyroxine are very rare, and when they do occur, they are usually due to inactive fillers in the tablet, not the hormone itself. A rash should still be evaluated, but it is not a typical adverse effect of over-replacement. Now, hyperactivity is correct. Too much thyroid hormone stimulates the nervous system, making clients restless, irritable, and unusually energetic. This is an early sign of overtreatment that the nurse must report promptly. Lastly, insomnia is correct. Because the metabolic and neurologic systems are in overdrive, clients may struggle to fall or stay asleep. This may seem like a minor complaint, but it is an important marker of thyroid hormone excess that signals the need for dosage review. Clinically, when levothyroxine is dosed too aggressively, clients may also report tremors, heat intolerance, unexplained weight loss, and nervousness. That is why the golden rule is to start with a low dose and gradually titrate upward, especially in older adults or those with heart disease. TSH and free T4 levels are monitored every 6 to 8 weeks after dose adjustments to ensure safety and effectiveness. Here is your Stancoast Pearl. Remember the overdrive trio: a racing heart, a restless body, and sleepless nights. These 3 are classic signs of overtreatment with levothyroxine. As a nurse, your job is to catch these early, advocate for timely lab checks, and educate your client that consistency in daily dosing is non-negotiable. By staying alert to these cues, you ensure therapy remains safe, effective, and life-sustaining. Let us continue with another advanced NCLEX-style practice scenario that challenges your ability to prioritize both immediate and long-term care interventions. A client presents with progressive fullness in the neck and is diagnosed with a large endemic goiter after several diagnostic studies. The nurse is developing a care plan to address both urgent safety concerns and ongoing management. The question is, which interventions are appropriate to implement for this client? Here are the options to consider. Option 1. Observe the client's respiratory status. Option 2. Elevate the head of the client's bed. Option 3. Provide a diet high in iodized salt. Option 4. Obtain an order for a soft diet. Option 5. Assess for high fever. Option 6. Administer prescribed antibiotics. The correct answers are options 1, 2, 3, and 4. Now, let us explore why. Choosing option 1, to observe the client's respiratory status, is correct because a markedly enlarged thyroid gland can compress the trachea, leading to airway compromise. Vigilant monitoring for stridor, dyspnea, accessory muscle use, or sudden voice changes is essential since severe obstruction can quickly progress to respiratory failure, making airway management the top nursing priority. Moving to option 2, elevating the head of the client's bed is another correct intervention. This position reduces tracheal pressure, promotes lung expansion, and decreases venous congestion in the neck, all of which relieve respiratory distress in clients with a large goiter. Transitioning to option 3, providing a diet high in iodized salt directly addresses the underlying cause of endemic goiter, which is chronic dietary iodine deficiency. By ensuring iodine intake, nurses support thyroid hormone production, prevent further enlargement, and contribute to long-term management. Shifting to option 4, obtaining an order for a soft diet is also correct, because an enlarged thyroid can press on the esophagus, causing dysphagia and discomfort with swallowing solids. A soft diet minimizes aspiration risk, facilitates nutrition, and maintains caloric intake, making it a vital nursing adjustment. Now, let us look at the incorrect options. Option 5, assessing for high fever, is not appropriate because endemic goiter is a deficiency disorder, not an infectious process. Fever is not characteristic, and its presence would suggest thyroiditis or another infection. Lastly, option 6, administering prescribed antibiotics, is incorrect because antibiotics have no role in treating endemic goiter. They are only warranted if a secondary infection occurs, which is not the case here. Here is a key clinical insight, also called the Stancoast Pearl: think airway first. In clients with large goiters, tracheal compression poses the most immediate danger. Nurses must always prioritize respiratory monitoring and positioning interventions before shifting focus to nutritional correction and long-term management. Remember, airway stability saves lives, while iodine repletion prevents future complications. Let us now shift into another NCLEX-style question that highlights the clinical findings a nurse must recognize in endocrine disorders. A client is undergoing treatment for Graves' disease, and the nurse is performing a physical assessment. The question is, which characteristic facial feature is most likely to be observed in this client? Here are the options. Option 1, bulging eyes. Option 2, bulbous nose. Option 3, thick lips. Option 4, large tongue. The correct answer is option 1, bulging eyes. When we break down the reasoning, Graves' disease, also called toxic diffuse goiter, thyrotoxicosis, Bastow's disease, or exophthalmic goiter, is an autoimmune condition in which thyroid-stimulating immunoglobulins overstimulate the thyroid gland, resulting in hyperthyroidism. A hallmark extrathyroidal sign is exophthalmos, or protrusion of the eyeballs, which occurs due to immune-mediated inflammation, swelling of orbital tissues, and fat deposition that push the eyes forward. This finding is so classic that it helps distinguish Graves' disease from other forms of hyperthyroidism. Looking at the options more closely, option 1, bulging eyes, is correct because exophthalmos is the most recognized facial feature of Graves' disease. It often comes with lid lag, swelling around the eyes, difficulty closing the eyelids, or even vision-threatening complications like corneal injury and diplopia. Nurses must monitor for dryness, photophobia, and ulceration while promoting protective measures such as lubricating drops, taping eyelids at night, and elevating the head of the bed. Option 2, bulbous nose, is incorrect, since nose enlargement is not related to thyroid disease but is more often seen in severe rosacea with rhinophyma. Option 3, thick lips, is also incorrect, as lip thickening occurs in acromegaly due to growth hormone excess, not in Graves' disease. Finally, option 4, large tongue, is not associated with Graves' disease either. Macroglossia is more often linked with hypothyroidism, Down syndrome, or amyloidosis. From a nursing perspective, the presence of exophthalmos requires proactive care to prevent complications. Nurses should educate clients about using sunglasses, applying artificial tears, and seeking treatment early if vision changes occur. Severe cases may even require corticosteroids, radiation therapy, or orbital decompression surgery. And here is your Stancoast Pearl, eyes out in Graves. Always remember that in Graves' disease, the autoimmune attack pushes the eyes outward due to fat and muscle inflammation in the orbit. This clinical clue is a key differentiator that you should never miss in both practice and the NCLEX. Let us now explore another critical NCLEX-style scenario that directly highlights medication safety in endocrine disorders. A nurse is preparing to administer propylthiouracil, also called PTU, to a client who has been newly diagnosed with Graves' disease. Before giving the first dose, the nurse must carefully consider what assessment question is most important to ask. Here are the options to evaluate. Option 1, do you have trouble swallowing? Option 2, do you prefer a liquid form of medication? Option 3, have you had digestive disorders in the past? And option 4, is there a possibility you could be pregnant? The correct answer here is option 4, asking, is there a possibility you could be pregnant? This is the priority because PTU has a significant teratogenic risk. Let me explain further. PTU is an anti-thyroid drug that works by blocking thyroid peroxidase, the enzyme needed for thyroid hormone synthesis, and by reducing peripheral conversion of thyroxine into triiodothyronine. It is particularly useful in acute thyrotoxic states such as thyroid storm. However, it crosses the placenta and can interfere with fetal thyroid development, potentially causing congenital hypothyroidism, also known as cretinism. This condition results in irreversible brain damage, cognitive impairment, and growth abnormalities if left untreated. Therefore, before the very first dose, pregnancy status must be verified. This is why the Food and Drug Administration has placed a black box warning on PTU due to risks of hepatotoxicity and fetal harm. Now let us analyze the other options. Asking, do you have trouble swallowing? Sounds reasonable but is incorrect. While difficulty swallowing could affect tablet intake, PTU can be crushed and taken with food, making it a manageable concern rather than a priority safety issue. Moving to the next distractor, do you prefer a liquid form of medication? Is incorrect because PTU is only manufactured as tablets. There is no standard liquid formulation available, so this question has no clinical relevance. Considering option 3, have you had digestive disorders in the past, is also not the right priority. Although gastrointestinal upset such as nausea or gastritis can occur, these side effects are mild compared to the potential consequences of fetal hypothyroidism. The best nursing practice is to first confirm pregnancy status before giving PTU. Along with this, the nurse should also monitor baseline liver function tests due to hepatotoxicity risk. Check complete blood counts because of the rare but dangerous complication of a granulocytosis, and teach clients to promptly report fever, sore throat, or right upper quadrant pain. Client education should also emphasize strict adherence to the prescribed schedule, since skipping doses can trigger a relapse of thyrotoxicosis. Here is your Stancoast Pearl for high-yield NCLEX success. When administering anti-thyroid medications, always think pregnancy check comes first. This is because fetal hypothyroidism is permanent and irreversible, while other side effects such as nausea or swallowing issues can be managed later. Safety for both the mother and fetus always comes before non-critical concerns. Let us smoothly move forward into another advanced NCLEX practice question that emphasizes both medication safety and client teaching. A nurse is caring for a client who has recently been started on propylthiouracil, also known as PTU, for the treatment of Graves' disease. Because this drug carries a serious risk of a granulocytosis, the nurse must prioritize client education and instruct the client to immediately notify the healthcare provider if which clinical problem develops. Here are the possible options to consider. Option 1, persistent sore throat. Option 2, occasional heart palpitations. Option 3, fatigue on exertion. And option 4, prolonged bleeding with trauma. The correct answer is option 1, persistent sore throat. Now, let us carefully break this down. Propylthiouracil is an antithyroid medication that works by inhibiting thyroid peroxidase, thereby reducing the synthesis of thyroid hormones, and by blocking the peripheral conversion of thyroxine into triiodothyronine. While it is effective in controlling hyperthyroidism and even useful in thyroid storm, PTU carries a rare but potentially life-threatening adverse effect: agranulocytosis, which is a severe depletion of neutrophils. Since neutrophils are critical defenders against bacterial infections, their absence leaves the client dangerously susceptible to infections. The earliest and most important clinical clue is a sore throat, often accompanied by fever and malaise. If this develops, the medication must be stopped immediately, and a complete blood count should be performed to verify white blood cell levels. Looking closely at the options, persistent sore throat is correct because it is the classic early red flag of a granulocytosis, and recognizing it early prevents progression to sepsis. Occasional heart palpitations, on the other hand, are more often related to the client's underlying hyperthyroidism and tend to improve as therapy stabilizes thyroid hormone levels, so they do not indicate a granulocytosis. Fatigue on exertion can have many nonspecific causes such as anemia, illness, or hypothyroid overcorrection, but it is not the key warning sign for this complication. Prolonged bleeding with trauma suggests platelet-related issues like thrombocytopenia, but it is not associated with PTU's agranulocytosis risk. From a clinical priority perspective, using NCLEX frameworks such as Maslow's hierarchy and safety guidelines, infection prevention takes precedence over comfort or non-specific symptoms. Because untreated infection can quickly progress to life-threatening sepsis, that is why persistent sore throat must be reported immediately. Here is your Stancoast Pearl to remember this easily. Sore throat plus PTU equals STATCBC. This means that if a client on PTU develops throat pain, it is always an emergency that requires immediate medical evaluation to protect the client's survival. Let us now continue shaping your NCLEX script with this advanced thyroid preparation question. Imagine this clinical setup. A 34-year-old client with Graves' disease is scheduled for a subtotal thyroidectomy after failing to achieve adequate control with antithyroid medications. The physician prescribes potassium iodide, also called Lugol's solution, at 4 drops orally every day for 10 days before surgery. During client teaching, the nurse must decide which instruction is the highest priority to emphasize. Here are the options to consider. First, swallow the drug quickly to avoid lingering taste. Second, take the drug on an empty stomach before meals. Third, dilute the drug in fruit juice or other liquids before taking. Fourth, chill the solution to reduce its unpleasant odor. The correct answer is option 3, dilute the drug in fruit juice or other liquids before taking. To unpack this, let us review the clinical reasoning and pathophysiology. Graves' disease is an autoimmune condition that causes hyperthyroidism by stimulating the thyroid gland to overproduce hormones. A subtotal thyroidectomy is chosen when medications alone cannot provide adequate control or when complications threaten the client's safety. In preparation, Lugol's solution is administered to acutely suppress thyroid hormone release and to shrink and devascularize the gland, which reduces the risk of thyroid storm and intraoperative bleeding. So why is option 3 correct? Lugol's solution has a strong metallic taste and can cause burning in the mouth, gum soreness, or gastrointestinal irritation. The safest and most practical instruction is to dilute the solution in juice, milk, or water to mask the taste and minimize mucosal irritation. This approach ensures better compliance and prevents oral discomfort during the preoperative phase. Now, let us consider why the other options are incorrect. Swallowing the drug quickly might help avoid taste but does nothing to reduce burning or irritation, so it is less safe than dilution. Taking the medication on an empty stomach before meals has no impact on absorption and provides no therapeutic advantage. Chilling the solution may reduce odor slightly, but it does not address the key safety and tolerability concerns that dilution solves. From a pharmacologic perspective, potassium iodide works by the Wolff-Chaikoff effect. This means that giving excess iodine briefly halts thyroid hormone synthesis and release, while also making the gland firmer and less vascular. It is critical to remember that iodine should only be started after antithyroid medications, such as methimazole or propylthiouracil, have already been initiated. Otherwise, paradoxical hormone overproduction could worsen hyperthyroidism. When teaching clients, nurses must stress essential safety points. Always dilute Lugol's solution. Preferably drink it through a straw to protect teeth and gums, and take it consistently at the same time each day. Clients should report sore throat, mouth ulcers, rash, or a metallic taste that persists despite dilution. Finally, remind them this is a short-term preoperative preparation, not a long-term treatment for Graves' disease. From an NCLEX strategy standpoint, the test is designed to present distractors that sound reasonable, like swallowing quickly or chilling the solution. But the highest priority answer is always the one that improves safety, adherence, and therapeutic effect. Therefore, dilution is the correct teaching. Stancoast. Pearl. When it tastes metallic and burns the gums, hide it in juice and spare the tongue. Now, let us dive into a critical surgical preparation question. A 34-year-old client with Graves' disease is scheduled for a subtotal thyroidectomy after anti-thyroid medications failed to provide adequate control. The physician prescribes potassium iodide, also known as Lugol's solution, for 10 days before surgery. During client teaching, the client asks the nurse to explain the purpose of this preoperative drug therapy. The nurse considers the following options. Could it be that it firms the thyroid gland so it is more easily removed? Might it decrease the overall length of postoperative recovery time? Could the correct explanation be that it reduces the vascularity of the thyroid gland, thereby decreasing the risk of postoperative bleeding? Or perhaps the teaching should emphasize that it eliminates the need for lifelong thyroid hormone replacement after surgery. Out of these possibilities, the correct answer is option 3. It reduces the vascularity of the thyroid gland, thereby decreasing the risk of postoperative bleeding. To explain why, let us review the clinical reasoning and pathophysiology. In Graves' disease, the thyroid tissue becomes hyperactive and hypervascular because of autoimmune stimulation of thyroid-stimulating hormone receptors. A subtotal thyroidectomy is chosen when medical therapy fails or when complications such as ophthalmopathy, cardiovascular strain, or airway compromise appear. Preoperative potassium iodide plays a vital role because it rapidly suppresses thyroid hormone release and shrinks the gland, while also significantly reducing its vascularity. This matters greatly since the thyroid gland is one of the most richly perfused organs in the body. Without this preparation, the client would face a much higher risk of hemorrhage during surgery, which could lead to airway obstruction or life-threatening hypovolemic shock. Now, let us briefly evaluate each option. Option 1, suggesting that iodide firms the gland so it is more easily removed, is not the priority focus. While the gland may become somewhat firmer, NCLEX emphasizes safety, and the essential rationale is bleeding risk reduction, not surgical handling. Moving to option 2, decreasing the overall length of postoperative recovery time sounds attractive, but recovery is influenced by many factors including airway stability, wound healing, and complications. Lugol's solution contributes indirectly, but this is not its primary function. Shifting our attention to option 3, reducing vascularity to lower bleeding risk is both accurate and safety-focused. It also decreases the chance of thyroid storm, a dangerous complication after thyroid manipulation. This is why it is the best answer. Finally, option 4, which states that iodide eliminates the need for lifelong thyroid hormone replacement, is simply false. Clients undergoing subtotal thyroidectomy often still develop hypothyroidism and require long-term levothyroxine therapy. Lugol's solution has no influence on that outcome. Here is a clinical pearl to lock this into memory. Iodide before incision means less blood and less storm. This phrase highlights that preoperative iodide reduces the gland's blood flow and suppresses thyroid hormone release, directly lowering the risk of two of the most life-threatening surgical complications, hemorrhage and thyroid storm. And for your NCLEX high-yield takeaway, always remember that the purpose of preoperative iodide therapy is complication prevention. When the exam presents this scenario, the safest and most accurate answer will be that it decreases vascularity and reduces bleeding risk, aligning with NCLEX's principle of prioritizing safety above all. Before diving into next case scenario, I want to give you something that could completely change your preparation. If you're aiming to pass on your very next attempt, the ultimate NCLEX crash course is your shortcut, already trusted by more than 100,000 nursing students who cleared their exams successfully. What makes it different? It's an all-in-one package designed to cover every part of your NCLEX prep, interactive live classes, and easy-to-watch. Recorded lectures, 5,000 exam-style practice questions, 30 complete practice tests, ebooks, and PDF notes for revision, a ready-to-use student planner, NGN questions broken down in detail. During comprehensive lecture, this isn't just another review, it's everything you need in one. Please scan the QR code right now, or use the link in the description to enroll instantly and grab free content, including PDF notes, practice tests, and NCLEX quizzes. You'll also get access to our Telegram and WhatsApp channels for even more free resources to keep you ahead. Let us transition into this important NCLEX-style scenario. A nurse is preparing a client for a subtotal thyroidectomy, and the key question is, preoperatively, which teaching point is the most critical to emphasize to ensure safety during the immediate postoperative period? Here are the possible answers to consider. First, techniques for changing positions. Second, reasons for performing leg exercises. Third, the necessity for daily dressing changes. And fourth, postoperative use of the incentive spirometer. The correct answer is option 1, techniques for changing positions. Before thyroid surgery, the nurse's highest priority is to teach the client how to support the head and neck when rising, sitting, or turning. This is crucial because the thyroidectomy incision is located in the anterior neck, where sutures and tissues are highly vulnerable. Improper neck movement after surgery can place dangerous tension on the incision line, disrupt sutures, or even cause airway compromise if swelling develops. Since airway obstruction is the most life-threatening complication of thyroidectomy, protecting the airway and wound stability takes priority over all other teaching points. Clients are taught to place both hands behind the neck and keep the head and neck aligned when moving from supine to sitting or turning. This prevents sudden extension or flexion that could cause bleeding, compromise airway safety, or even injure nearby structures like the recurrent laryngeal nerve. Looking at option 2, reasons for performing leg exercises. This is indeed helpful for preventing venous stasis and reducing the risk of blood clots after surgery. However, it is a general postoperative teaching point and not specific to the unique airway-related risks of thyroidectomy. Moving to option 3, the necessity for daily dressing changes. This is not accurate. After thyroidectomy, the first dressing is usually left in place for 24 hours and is typically removed by the surgeon. Frequent dressing changes can actually increase infection risk or disrupt wound closure. Finally, option 4, postoperative use of the incentive spirometer, is important for preventing pneumonia and atelectasis, but it is not the most urgent priority when compared to airway and incision safety. Pulmonary hygiene can be delayed, but airway obstruction from improper neck movement can be life-threatening immediately. Here is the Stancoast Pearl. In thyroidectomy clients, the neck is sacred. Teach them to protect it first. Airway stability always outweighs circulation or comfort concerns. And the NCLEX high-yield takeaway is this. When preparing a client for thyroid surgery, the single most critical teaching point is how to support the neck and maintain proper head positioning during movement, because this directly prevents airway compromise and wound disruption. All other general postoperative teachings come after airway protection is secured. Let us begin with this critical scenario on postoperative thyroidectomy care. A nurse is caring for a client immediately after a total thyroidectomy, and the nurse recalls that airway compromise is the most life-threatening complication. The question is, which emergency item must be kept at the client's bedside to ensure rapid intervention if acute airway obstruction occurs? Here are the options to consider: a dressing change kit, a tracheostomy tray, an ampule of epinephrine, or a mechanical ventilator. The correct answer is option 2, tracheostomy tray. This is the single most important item to keep at the bedside because it directly addresses the greatest risk, which is airway obstruction. Now let us carefully analyze why this is correct. After a thyroidectomy, complications like hemorrhage, hematoma, edema, or laryngeal nerve injury can all lead to airway compromise. Since the thyroid gland sits right in the anterior neck, even minimal swelling can quickly narrow the airway. In such cases, the nurse must anticipate the emergency. Having a tracheostomy tray readily available means the healthcare team can create an emergency surgical airway within seconds if intubation is impossible due to swelling. This proactive step can save a life. Shifting our attention to why option 1, the dressing change kit, is incorrect. While wound care is necessary, it does nothing to address airway obstruction. Changing the outer dressing cannot relieve compression caused by bleeding or swelling under the incision. Safety priorities always place airway first before incision care. Moving on to option 3, the ampule of epinephrine. This too is incorrect. Epinephrine is vital in cases such as anaphylaxis or cardiac arrest, but thyroidectomy complications are mechanical, not allergic. Having epinephrine without a way to establish an airway does not solve the problem. Finally, let us examine option 4, the mechanical ventilator, which is also incorrect. A ventilator is only effective if there is an open airway to deliver oxygen. If the airway is completely blocked, no ventilator can push air through. Establishing a tracheostomy airway must come first before a ventilator can even be useful. Here is the Stancoast pearl. Always think airway before anything. After thyroid surgery, having a tracheostomy tray at the bedside is not optional. It is a life-saving standard. And here is your NCLEX high-yield takeaway. After a thyroidectomy, stridor, choking, difficulty breathing, or sudden voice changes are red flags for airway obstruction. The nurse must immediately be ready with a tracheostomy tray so the team can secure the airway without delay, preventing hypoxia and cardiac arrest. Let us now transition into this important post-operative scenario. A nurse is providing immediate care to a client who has just undergone a subtotal thyroidectomy for hyperthyroidism. During the handoff, the nurse remembers that positioning is one of the most critical priorities after this surgery because it directly influences airway safety and recovery. The question becomes, which position should the nurse maintain for this client to optimize airway patency, reduce edema, and support healing? Here are the options to consider: supine, Sims, semi-Fowler's, or recumbent. The correct answer is option 3, semi-Fowler's. Semi-Fowler's position, with the head of the bed elevated about 30 to 45 degrees, is the safest and most therapeutic choice after a thyroidectomy. Here is the expanded rationale. First, from a clinical reasoning perspective, the greatest risk after thyroid surgery is airway obstruction, which can result from swelling, bleeding, or hematoma formation around the surgical site. Because the thyroid gland is in the anterior neck and lies next to the trachea, even a small amount of edema can rapidly compromise breathing. By elevating the head, semi-Fowler's position decreases venous congestion, reduces swelling, and makes it easier for the lungs to expand, while also allowing nurses to closely observe the neck for signs of bleeding. Next, let us connect this to pathophysiology. During surgery, blood vessels and lymphatic channels in the neck are manipulated. If the client is lying flat, venous return slows and fluid accumulates, which can worsen swelling. Semi-Fowler's position uses gravity to drain secretions and fluids away from the neck, lowering the risk of airway obstruction and also decreasing pressure on the suture line, which helps prevent wound complications such as dehiscence or hemorrhage. From a safety standpoint, the NCLEX always emphasizes the ABCS: airway, breathing, and circulation. Positioning the client upright in semi-Fowler's directly supports airway patency, which is the top priority. Choosing positions that flatten the client or obstruct monitoring of the surgical site may place the client at risk of hypoxia and delayed recognition of complications. Now, let us carefully analyze why the other options are incorrect. Option 1, supine, is unsafe because lying flat increases venous pressure in the neck, promotes swelling, and makes airway obstruction more likely. Option 2, Sims, is a side-lying position most useful for unconscious patients or procedures like enemas, but it does not relieve neck edema or allow proper surgical site monitoring. Option 4, recumbent, which usually implies lying flat in bed, is very similar to supine and provides no airway protection, while also obscuring early signs of bleeding or hematoma formation. Here is your Stancoast pearl. Neck surgeries need elevation. Remember that semi-Fowler's position is the go-to choice for clients after subtotal or total thyroidectomy because it prevents dangerous swelling, protects the airway, and promotes healing. Finally, the NCLEX high-yield takeaway is this. For any surgery involving the head, neck, or airway, always think of airway patency first. After thyroidectomy, semi-Fowler's is the safest position because it reduces edema, optimizes breathing, and helps you catch complications early. This is the positioning answer you must never miss on your exam. Let us move into this crucial post-operative scenario together. A client has just undergone a subtotal thyroidectomy for treatment of hyperthyroidism, and the nurse is planning immediate interventions to support safe recovery. The key question is, which pulmonary hygiene activity should the nurse consult the physician about before encouraging the client to perform? The options to consider are forced, coughing, deep breathing, ambulating, or dangling the legs from the bed. The correct answer is option 1, forced coughing. Here's the detailed reasoning behind this. After a subtotal thyroidectomy, airway obstruction is the most life-threatening complication. The thyroid gland lies in the anterior neck, right next to the trachea, and it is surrounded by a highly vascular area. Any disruption, such as bleeding or hematoma, can rapidly compress the airway. Forced coughing exerts sudden intrathoracic and venous pressure, which may disrupt delicate sutures and precipitate hemorrhage. The resulting swelling or hematoma can compromise the airway and trigger respiratory distress. Therefore, forced coughing should not be encouraged unless specifically cleared by the physician. Now, let us look at why the other options are considered safe. Deep breathing, without forceful coughing, is encouraged because it expands the lungs, prevents atelectasis, and improves oxygenation without placing undue pressure on the surgical site. Ambulating early is a cornerstone of safe recovery, as it prevents thromboembolic events, stimulates circulation, and improves gastrointestinal motility, all without jeopardizing neck integrity. Similarly, dangling the legs from the bed is a gentle way to prepare the client for mobilization. It supports orthostatic tolerance and circulation and does not stress the surgical wound. Here's the key NCLEX takeaway. In clients recovering from thyroid surgery, airway management always comes first. Activities that promote recovery, such as deep breathing, ambulation, and leg dangling, are safe. But anything that risks airway compromise, like forced coughing, requires physician consultation. And finally, let me give you the Stancoast Pearl. Thyroid plus trauma equals airway first. Any action that increases neck pressure, venous congestion, or surgical site strain, whether it is forceful coughing, straining, or vigorous suctioning, can lead to bleeding and airway obstruction. Always prioritize airway safety above all other postoperative routines. Let us transition into this critical postoperative scenario together. A nurse is providing immediate postoperative care for a client who has just undergone a subtotal thyroidectomy. Since bleeding is one of the most serious complications in the first 24 hours, the question becomes, which intervention is most appropriate to detect incisional bleeding at the earliest stage? Here are the options. First, observe for signs of hypovolemic shock. Second, assess for dampness at the back of the client's neck. Third, remove the dressing to directly inspect the wound. And fourth, weigh all gauze dressings before and after changing. The correct answer is option 2, assess for dampness at the back of the client's neck. Now, let us carefully unpack the reasoning behind this choice. After a thyroidectomy, the surgical site is located in a highly vascular area, and bleeding can rapidly become life-threatening if not detected early. Because of gravity and the natural slope of the neck, blood tends to pool at the back of the neck, underneath the dressing or pillow, making direct visual inspection of the incision unreliable. By gently placing a gloved hand behind the neck to check for dampness, the nurse can quickly detect hidden bleeding that would otherwise be missed. This early recognition is essential to prevent airway obstruction caused by a compressive hematoma and to intervene before the client progresses to hypovolemic shock. In addition, the nurse should consistently check the pillow, linens, and gown during position changes to identify fresh drainage as part of comprehensive post-operative monitoring. Looking at the incorrect options, let us first consider option 1. Observe for signs of hypovolemic shock. Although this is important, systemic signs such as tachycardia, hypotension, pallor, and restlessness occur only after significant blood loss has already taken place. NCLEX emphasizes early detection strategies, and waiting until shock develops reflects delayed intervention. Turning to option 3, remove the dressing to directly inspect the wound. This is incorrect because the immediate postoperative dressing should not be removed by the nurse. Removing it risks disrupting sutures and triggering more bleeding. Instead, the nurse can reinforce a saturated dressing but should never remove the initial one without explicit provider orders. Finally, examining option 4, weigh all gauze dressings before and after changing. While weighing dressings may be a precise method in research or intensive care settings, it is impractical for bedside thyroidectomy care. What truly matters in this context is the early recognition of concealed bleeding, not the exact milliliters of blood lost. To wrap this up with high-yield pearls, remember that airway compromise is always the top priority in thyroid surgery, as even a small hematoma can obstruct the trachea. Checking for dampness at the back of the neck represents an early detection strategy, while systemic signs of shock represent late recognition. Also, remember that nurses do not independently remove surgical dressings, but serve as the first line of defense in identifying complications. From an NCLEX test-taking perspective, when presented with a choice between systemic monitoring and site-specific early detection interventions, always prioritize the action that prevents deterioration rather than responds to it. Let us move into this important surgical nursing scenario together. A nurse is caring for a client who has just undergone a subtotal thyroidectomy, and in the immediate postoperative period, the critical concern is identifying any injury to the recurrent laryngeal nerve. So the question becomes, which bedside assessment technique is the most reliable and appropriate to detect laryngeal nerve damage? Here are the options to consider. First, turning the client's head from side to side. Second, observing the client swallowing. Third, looking for tracheal deviation. And fourth, asking the client to say, "ah." The correct answer is option 4, asking the client to say, "ah." Now, here is the expanded rationale. The recurrent laryngeal nerve runs directly adjacent to the thyroid gland and is at significant risk of being stretched, bruised, or severed during surgery. This nerve controls the vocal cords, which are essential for speaking and protecting the airway. If the nerve is injured, the client may present with hoarseness, stridor, or in severe cases of bilateral damage, airway obstruction that can quickly become life-threatening. The quickest and most accurate bedside test for this complication is simply asking the client to vocalize or say, "ah," because this directly reveals whether the vocal cords can move properly. Any persistent change in voice quality, such as hoarseness or inability to phonate, is a red flag that should be reported immediately to the surgeon. Turning to the incorrect options, let us start with option 1, turning the client's head from side to side. This maneuver only assesses neck mobility and muscular discomfort, and it does not provide any information about vocal cord or nerve function, making it irrelevant in detecting laryngeal nerve damage. Moving on to option 2, observing the client swallowing. While swallowing difficulties can occur if nerve damage is severe, this assessment is not specific or sensitive for laryngeal nerve injury. It evaluates aspiration risk and esophageal function rather than vocal cord integrity. Next, option 3, looking for tracheal deviation. This is a vital airway assessment but serves a different purpose. Deviation of the trachea signals issues such as hematoma formation, swelling, or pneumothorax, none of which directly evaluate the recurrent laryngeal nerve. Finally, circling back to option 4, asking the client to say, "ah." This is the most accurate and immediate way to assess recurrent laryngeal nerve function, because it requires the vocal cords to move, and any disruption can be heard instantly as hoarseness, stridor, or absence of sound. High-yield clinical points include remembering that temporary hoarseness can occur from edema right after surgery, but persistent or progressive hoarseness strongly suggests nerve injury. Bilateral recurrent laryngeal nerve damage is rare, but can cause complete vocal cord paralysis, leading to airway obstruction that requires emergency intervention. In the first 24 hours post-thyroidectomy, nurses must monitor closely for both hemorrhage and airway compromise, which includes assessing the ability to speak clearly. Here is your NCLEX success tip. When you think about assessing for laryngeal nerve injury, remember the quick bedside test. Ask the client to speak. This is the fastest, most reliable way to catch complications early. And for a memory shortcut, here's the Stancoast Pearl. Voice is the vital sign of the laryngeal nerve. If the voice disappears or changes dramatically, always suspect nerve injury immediately. Now, shifting our focus to the immediate post-operative period, imagine a client who has just undergone a subtotal thyroidectomy. The nurse knows that one of the most critical risks after this surgery is injury or accidental removal of the parathyroid glands, which are responsible for regulating calcium. This brings us to the question, which client statements should alert the nurse to early signs of hypocalcemia? Here are the possible options. Option 1, I feel like I could vomit. Option 2, my lips feel numb and tingly. Option 3, light seems to bother my eyes. Option 4, I feel weak when I walk. Option 5, I have cramps in my legs. Option 6, I feel like my throat is constricting. The correct responses are options 2, 5, and 6, which are numb and tingling lips, muscle cramps in the legs, and a sensation of throat constriction. Let me explain why. When we understand the pathophysiology, it becomes clear that during a subtotal thyroidectomy, the parathyroid glands can be inadvertently damaged or removed. These tiny glands secrete parathyroid hormone, which is vital for maintaining calcium balance. A sudden drop in parathyroid hormone leads to hypocalcemia, often within hours. Because calcium stabilizes neuromuscular activity, low levels cause neuromuscular irritability that shows up early as tingling, cramping, or throat tightness. If not corrected, this can progress to tetany, seizures, or even life-threatening airway obstruction. Looking at option 1, I feel like I could vomit. This is incorrect because nausea is more likely related to anesthesia or opioid use rather than hypocalcemia. Option 2, my lips feel numb and tingly, is correct since perioral numbness is a hallmark early warning sign and should trigger an immediate calcium level check and readiness for interventions like intravenous calcium gluconate. Moving to option 3, light seems to bother my eyes. This is incorrect because photophobia is unrelated to calcium levels and is usually associated with neurological or ocular issues. Option 4, I feel weak when I walk, is also incorrect, since generalized weakness is common after surgery but does not specifically point to calcium imbalance. Option 5, I have cramps in my legs, is correct because painful muscle cramping reflects increased nerve excitability and is one of the most frequent clinical complaints of hypocalcemia. Finally, option 6, I feel like my throat is constricting, is correct and represents a red flag symptom of laryngospasm, which can compromise the airway and requires urgent intervention. Here is a quick set of clinical pearls. Remember Chvostek's and Trousseau's signs as late but objective findings of hypocalcemia. Always prioritize airway, so any throat tightness or stridor after thyroid surgery is an emergency. And keep in mind that hypocalcemia leads to muscle excitability, while hypercalcemia leads to muscle weakness and lethargy. For NCLEX safety, any postoperative thyroid client with airway symptoms should be managed under the ABC framework with immediate escalation. Let us now dive into another critical NCLEX scenario that highlights the importance of quick recognition and decisive action. A nurse is caring for a client on the first postoperative day following a subtotal thyroidectomy. Suddenly, the nurse becomes concerned that the client may be developing a thyroid crisis, also known as thyroid storm. This is a life-threatening complication caused by the massive release of thyroid hormones. The question asks, which of the following clinical findings should the nurse recognize as requiring immediate notification of the healthcare provider? Here are the possible options. Option 1, high fever. Option 2, falling blood pressure. Option 3, regular noisy respirations. Option 4, hand spasms. Option 5, heart palpitations. Option 6, decreased urine output. Moving to the correct responses, the right answers are Option 1, high fever, and Option 5, heart palpitations. High fever is a classic hallmark of thyroid crisis, where temperatures can soar above 40 to 41 degrees Celsius, or 104 to 106 degrees Fahrenheit. This extreme hypermetabolic state generates tremendous heat and can rapidly overwhelm the body, leading to multi-organ dysfunction if not controlled. Immediate interventions like cooling measures, antipyretics, and aggressive supportive care are essential. Heart palpitations, on the other hand, signal the severe cardiovascular hyperstimulation seen in thyroid storm. The thyroid hormone surge dramatically increases beta-adrenergic sensitivity, leading to tachycardia, atrial fibrillation, and even heart failure. Clients often describe their heart as racing or pounding, and this is a red flag for hemodynamic instability and possible sudden cardiac death without prompt intervention. Shifting to the incorrect responses, falling blood pressure may seem concerning, but it is not an early feature of thyroid storm. In fact, hypertension is more typical in the initial stages. Hypotension usually develops later if cardiovascular collapse occurs, so while it must be monitored, it is not a defining indicator. Regular noisy respirations do not reflect thyroid crisis. Instead, they point toward airway obstruction caused by laryngeal edema, tracheal compression, or hypocalcemia-induced laryngospasm, serious issues but distinct from thyroid storm. Hand spasms indicate hypocalcemia, a complication due to accidental parathyroid removal or injury during surgery, not thyroid hormone excess. Similarly, decreased urine output suggests dehydration or renal compromise, but it is not specific to thyroid storm, and therefore not a diagnostic clue in this context. From a clinical integration standpoint, thyroid storm is a medical emergency that demands immediate recognition. Nurses should stay vigilant for red flags such as hyperpyrexia, severe tachycardia, palpitations, diaphoresis, agitation, and altered mental status. Rapid notification of the provider allows initiation of life-saving therapies, including beta blockers like propranolol, anti-thyroid agents such as propylthiouracil or methimazole, iodine preparations, corticosteroids, and comprehensive supportive measures. Delay in recognizing these warning signs significantly increases mortality risk. Here is the Stancoast Pearl to lock this into memory. Think hot and fast. If your thyroidectomy client suddenly presents with an extreme fever and a racing heart, always suspect thyroid storm. These exaggerated signs of hypermetabolism help you distinguish this emergency from other common postoperative complications. Now, let us move into another life-saving scenario that tests both knowledge and quick nursing judgment. A client has developed an acute thyroid crisis following a subtotal thyroidectomy, which is a true endocrine emergency caused by a sudden surge of thyroid hormones. This leads to profound hypermetabolism, cardiovascular instability, and dangerous hyperthermia. The critical question is, which nursing interventions are most appropriate at this time? Here are the possible options. The first option is to take the client's vital signs at least every hour. The second option is to assess Trousseau's sign every shift. The third option is to limit the client's activity. The fourth option is to administer antipyretics per order. The fifth option is to encourage a diet high in iodized salt. And finally, the sixth option is to make sure intravenous calcium gluconate is available. The correct responses are option 1, option 3, and option 4. Let me walk you through the reasoning behind each one. Beginning with option 1, taking the client's vital signs at least every hour is correct because thyroid crisis causes life-threatening instability, including rapid tachycardia, arrhythmias, hypertension that may progress to hypotension, and extreme hyperpyrexia, where temperatures may soar above 40 to 41 degrees Celsius, or 104 to 106 degrees Fahrenheit. Hourly monitoring provides an early warning system, allowing nurses to intervene quickly and prevent cardiac collapse or multi-organ failure. Switching over to option 2, assessing Trousseau's sign every shift is incorrect. While it is true that hypocalcemia can occur after thyroid surgery due to accidental parathyroid damage, this is not the immediate concern in thyroid storm. The priority is stabilizing vital signs and addressing the endocrine emergency, not monitoring for hypocalcemia at this stage. Moving on to option 3, limiting the client's activity is correct because bed rest reduces metabolic demand and decreases strain on the cardiovascular system. Activity increases oxygen consumption and workload on a heart already stressed by tachyarrhythmias, making rest a cornerstone of nursing care during thyroid storm. Next, option 4 is also correct. Administering antipyretics per order is vital because hyperthermia must be controlled aggressively. Acetaminophen helps lower dangerously high temperatures, but aspirin must be avoided since it displaces thyroid hormones from plasma-binding proteins, worsening the crisis. Nurses also implement adjunct cooling measures like ice packs and cooling blankets to enhance safety. As for option 5, encouraging a diet high in iodized salt is incorrect because dietary salt does not deliver therapeutic iodine levels. Pharmacologic iodine solutions, such as Lugol's solution, are used under strict medical guidance. A high-salt diet would simply worsen hypertension and fluid retention, which are already dangerous in thyroid storm. Finally, option 6 is incorrect. Keeping intravenous calcium gluconate available is appropriate when hypocalcemia occurs after parathyroid injury, but it has no role in managing thyroid storm. The priority here is controlling hypermetabolism, not correcting calcium imbalances. Here is the Stancoast Pearl to lock this in. Think of thyroid storm as a hyper 3 crisis: hyperthermia, hypercardia, and hypermetabolism. Every nursing action should aim to cool the body, stabilize the heart, and conserve energy. If an intervention does not target one of these 3 priorities, it should not be considered the focus during this emergency. Let us move forward into another advanced NCLEX-style scenario that highlights the importance of monitoring for medication safety. A client who recently underwent a thyroidectomy has just begun thyroid hormone replacement therapy with levothyroxine. The nurse knows this therapy must be closely monitored to avoid both under-replacement and over-replacement of thyroid hormone. The critical question is, Which assessment findings would indicate that the client is receiving excessive thyroid hormone replacement? Select all that apply. Here are the options to consider. The first option is hyperglycemia. The second option is tachycardia. The third option is insomnia. The fourth option is hirsutism. The fifth option is tremors. And the sixth option is hypertension. The correct responses are option 2, tachycardia, option 3, insomnia, option 5, tremors, and option 6, hypertension. Now let us carefully reason through the correct answers. Tachycardia is correct because excess thyroid hormone stimulates beta-adrenergic receptors, leading to an increased heart rate and palpitations. If untreated, this can progress to arrhythmias such as atrial fibrillation or even precipitate heart failure, particularly in older clients or those with cardiac history. Insomnia is also correct because elevated levels of thyroxine overstimulate the central nervous system, creating restlessness and difficulty sleeping. This mirrors the pattern seen in hyperthyroidism and is a classic warning sign of overtreatment. Tremors represent another correct option, as sympathetic overdrive caused by excess thyroid hormone leads to fine hand tremors, which can interfere with activities of daily living and reflect neurologic irritability. Hypertension completes the list of correct findings since overreplacement increases cardiac output, myocardial oxygen demand, and vascular sensitivity to catecholamines, all of which contribute to elevated blood pressure and long-term cardiovascular strain. On the other hand, let us also clarify the incorrect options. Hyperglycemia, listed as the first option, is not a hallmark sign of levothyroxine overtreatment. While thyroid hormone can mildly influence glucose metabolism, sustained hyperglycemia is much more strongly associated with corticosteroid therapy. Hirsutism, presented as the fourth option, is likewise unrelated to thyroid hormone therapy. Instead, excessive androgen production, such as in polycystic ovary syndrome or adrenal disorders, is the typical cause of unwanted hair growth. To conclude with a clinical insight, the principle of start low and go slow is essential when initiating thyroid replacement, particularly in older adults and clients with cardiovascular disease. Overtreatment mimics hyperthyroidism and sharply raises cardiac risk, so nurses must remain vigilant for early red flags. And here is a Stancoast pearl to seal this concept. Remember the overdrive trio: a racing heart, restless nights, and shaking hands. These are the classic early signals of levothyroxine overtreatment, and prompt recognition can make the difference between safe recovery and dangerous complications.